Good evening. The case for today, which is under query or for discussion, is an RS case. I have put it as not everything is COVID or COPD because this is an era where we tend to put all diagnosis and all breathing difficulty as COVID and all bullays or all smokers as COPD. This is a 47-year-old male who had a history of shortness of breath since just 10 days' time. It was a short history, and he had cough with expectoration with no history of hemoptysis, chest pain, or hematuria, or palpitation, or oliguria. He had history of fever since last 5 to 6 days' time. This is his only presenting complaint, and he came to the hospital with this history of breathing difficulty. Similar illness was not present in the past. He had no history of COPD, no history of bronchial asthma, no history of hospital admissions, no radiological evaluation or chest medicine evaluation done in previous, no history of tuberculosis. He's not on any drugs, not on any steroids. He's a smoker. He's a stone grinder by work for more than last 20 years time. Normal bowel and bladder habits. In examination, remarkably, he had hypoxia with a desaturation in room air of 60% and 90% in 15-liter O2. Respiratory rate, he was tachypneic. There were no pallor, no lymphadenopathy. Grade 2 clumping was present. Bilateral pityal edema was not present. In chest, bilateral air entry is present. There is no rhonchi, but diffuse fine crepitations were present. Other systems were normal. Even CVS was normal. No evidence of raised JVPO, feature suggestive of LV or RV failure. CNS was normal. There is no neurocutaneous markers or no feature suggestive of ash leaf coats or subungual thickening or nothing. In the investigation done in CBC, the total count was mildly elevated with a polymorph predominance. LFT was normal. In RFT, creatinine was marginally elevated with an urea of 50. There is no previous records available to compare. LDH initially done on 5/10/2022 was 946. A repeat LDH on the very next day showed 106. CRP is 94. D dimer is just marginal or equivocal of 785 nanograms per ml, which is not much significant. PTINR is 1.4 and ECG normal. ABG, which shows type 1 respiratory failure. The most important reason for today's discussion is the CT finding we had for this patient. As you scroll above, you will see the length window of the patient from down up, where you can see multiple cystic lesions, multiple cysts involving both lobes of both sides of the length, involving almost all areas of the all lobes of the lengths or all zones of the lengths. You can see the involvement of multiple cystic lesions. Apart from that, you can see diffuse ground glass opacities also in the patient's both lengths. So this is a case of intraparenchymal cystic lesions with adjacent ground glass opacities and some septal thickenings. There are also some bullays and emphysematous changes also in the CT of this patient. And there's a still image of the same patient which shows the significant finding in the lung window that is showing multiple bullae with ground glass opacity of the intercystic lesions, multiple cystic, not bulla, multiple cyst with intercyst spaces showing some ground glass opacities. So, while Marcus was sent, it was negative. SARS-CoV-2 was negative. Influenza sample for H1N1, H1N1 variant of H275Y variant, H3N3, Influenza B, Yagamata, Influenza B, Victoria, all were sent, which was negative. So this is our case. And so to summarize the positive findings, history-wise, he is a smoker, strong grinder by occupation, present with history of breathing difficulty, which is short duration, with history of fever, no hemoptysis, no chest pain, no hematuria, no oliguria, no feature suggestive of volume overload, no high risk behavior of uh, immunocompromised state, no past history of similar illness, no history of seizures. Examination wise, patient is dyspneic, hypoxic, grade 2 clubbing, RS finding, bilateral air entry present with diffuse crepitations, no definitive Vs. No neurocutaneous markers, no features of volume overload, no features of cardiac failure. Investigation wise, type 1 respiratory failure, marginally deranged RFT, CT chest, which is suggestive of multiple cystic lesions in the lung with intercyst or intraparenchymal GGOs, intraparenchymal cystic lesions with GGOs. Negative for viral markers, negative for COVID, negative for influenza. So with this, the discussion of the case ends here. So here is a point of dilemma. What are we dealing with? I'll be glad to receive your inputs and receive your suggestions for the progress of these patients. Thank you.